Welcome, everyone, and thank you for joining. My name is Angelica Cardenas, and I'm a health educator for community health at Atlantic Health System. Today's webinar, No Need to Fear This October, Understand Your Risk of Breast Cancer, is presented by Lynn Tamburino, nurse practitioner in breast surgery, Morristown Medical Center. Before we begin, I have a few announcements. This webinar is being recorded and all participants are muted. If you have questions, please use the question and answer button at the bottom of your screen and use the chat button for comments. We will try our best to get through all the questions at the end of the presentation. At Atlantic Health, we've combined expert care with comfort and convenience to offer a thoughtful mammogram experience that prioritizes your health and your well-being. With advanced breast imaging technology, we ensure great accuracy and comfort. Plus, we make booking stress-free with easy online scheduling and flexible appointment times at more locations near you. Because this isn't just a mammogram, it's a mammogram with more peace of mind. Now I will hand it over to Lynn. Thank you, Lynn. Just a moment to give you remote control. There you are.
Like I said, I had to unmute myself. Good afternoon, everybody. My name is Lynn Tamburino. As Angelica stated, I'm a nurse practitioner. I work with the breast surgery practice at Morristown Medical Center. I've been with this practice approximately 9 years. I've actually been with Atlantic Health for 39 years. So I'm happy to be here today to talk to you a little bit about breast cancer risk and things that you can do to lower your risk of breast cancer. All right, let's just see here. So we can't really talk about breast cancer without going through some of the facts and figures. It is the number one diagnosed cancer among American women. And right now, especially during Breast Cancer Awareness Month, we are hearing all those statistics on the radio and on TV about that. About 1 in 8 women will develop breast cancer. That is true, and actually in the Northeast here, it's actually more like 1 in 7. The average age of diagnosis is 63. They don't have the final statistics out yet for 2023 numbers, but it was estimated that nearly 300,000 new cases of breast cancer would be diagnosed in women. And yes, men do get breast cancer, although it's very uncommon, only about 2,800 cases. And then around 43,000 women are expected to die from it. Now, those numbers and the deaths from breast cancer have really significantly decreased, and they continue to decrease. And that's for a variety of reasons. Early detection is a big thing. So, as you see at the bottom of the screen, and I'm going to mention this multiple times, that 95% of breast cancers are curable if you find them on routine imaging. So, that is just simply a mammogram. And then the other things is there's been a lot of treatment advances. So things like immunotherapy have really progressed. So women are living longer, especially even with metastatic disease. The use of hormone therapy replacement has did decrease. We're going to talk a little bit about that a little bit later in the presentation because it is making a little bit of a comeback. And just women being more aware of breast cancer and their breasts themselves. And interestingly enough, only about 5 to 10% of all breast cancers are hereditary. Everybody's always surprised about that, but it is just a small amount. So it's not as common as people would think it is. And when we talk about ethnicity, Caucasian women are more likely to develop a breast cancer, but African American women are more likely to be diagnosed at younger ages. They also tend to get more aggressive breast cancers. Um, and some of that they think is attributed to the African American population tend not to go for their mammograms and their screenings for some reason. So there's not a lot of early detection there, which can add to the fact that they're more likely to die from their breast cancers because it's not discovered until a little later on. The Asian, Hispanic, and Native American women have a lower risk. And when we go back to that genetic mutation, is the BRCA mutation, which everybody hears about. And Ashkenazi Jewish population has a higher risk of breast cancer for that reason. Oops. Okay, so we're going to talk about risk factors. And these are risk factors that you cannot change. So you can't change the gender you were born with at birth. You can't change your age, your race. And then there's the factors of the early first period and late menopause. So these are important because most breast cancers are fed by hormones. So when you have a lot of exposure to hormones like estrogen and progesterone or longer periods of time, your risk goes up because 85% of breast cancers are fed by those hormones. And we will talk about that a little bit later. But so having an early period like age 10 and a late menopause close to 60 can really contribute to your risk factors. Dense breast tissue, I will talk about a little bit later, but so women with dense breasts, that you can't change that factor. Frequently, patients' breast tissue density goes down once they hit menopause because a lot of it is fed by hormones or driven by those hormones. If you've had an abnormal breast biopsy or you've had a history of breast cancer, your risk is higher than the general population. There are some links between breast cancer and other cancers. So, other cancers like ovarian, pancreatic cancer, prostate cancer, or melanoma. Frequently, those are all can be associated with a genetic mutation, but when they're linked together, your risk for breast cancer is higher. It is not common to have radiation to the chest wall, but there are certain types of cancers that young women may have radiation to their chest wall for, or men. But if you have that radiation when your breast tissue is still developing between the ages of 10 and 30, then you are at maybe at elevated risk. So things that you can change. So these are some risk factors that are um, um, things that you can change. So physical inactivity or being overweight. So we as women, we store hormones in our fat. The more fat we have, the more ability we have to grow the most common type of breast cancer. So it's more really about being physically active and being lean. So when we replace that fat with muscle, our risk does go down. Pregnancy and breastfeeding, again, we're interrupting that cycle of the normal hormones. So your risk does go down if you have a earlier pregnancy. And for breastfeeding, for every 12 months of breastfeeding, your personal risk goes down by about 4%, according to the literature. Now, it's not minus 4% of your risk, it's 4% of your personal risk. So it's not as much as one would think or hope for all that hard work. And hormone replacement therapy, again, we'll talk about that a little bit later. That also is a factor that you can change. Cigarette smoking and alcohol, we'll talk about also, but those two things also can contribute to your risk. So I do want to take a minute to talk about breast tissue density. Now, we talked about how this does increase your risk. So breast tissue density, women with dense breasts are twice as likely to develop a breast cancer. And also that's much harder to see through. And I like using this slide because the images to the left, the least dense breast tissue is all the way to the left, the most extreme is to the right. So when we talk about the non-dense breast tissue, it's more like looking through a glass of water, whereas the extremely dense breast tissue is more like looking through a glass of milk. So women with dense tissue, their mammogram carries about a 10 to 20% false negative because it is harder to actually see through that tissue. So fatty tissue on the left and the extremely dense on the right, you can see the difference there. So it is important to know what the density of your breast tissue is, and that is listed on your mammogram reports. I did throw this little funny in here, and it's always hard to give a talk on Zoom because you never know whether anybody finds it entertaining. But the reason why I put this one up was not only for a chuckle, but it doesn't have anything to do with how your breasts appear on the outside. So your breasts can be sagging all the way down, but they may still be dense on the inside. So it's really how you look on imaging, not how you look on the outside. So this is just an example. Every woman by law, when they have their mammogram, must receive their mammogram results. Usually it's by mail. But when they describe the report, they do talk about breast tissue density. And again, by law, they must put in the report the New Jersey breast tissue density law. So you'll notice that on all of your mammogram reports. Sometimes they're a little difficult to interpret. And I'm using this as an example because I frequently hear patients tell me, well, I have dense breast tissue. But frequently patients don't have dense breast tissue. You have to actually read your report in more detail in order to see whether your breast tissue is dense. Just because the density law appears on there does not mean that you actually have dense tissue. So this is just an example of a portion of a report that came from actually Morristown, where you see to the left, I've highlighted, it says heterogeneously dense breast tissue. And then you have to look over on the right side and you see that the 4 categories and heterogeneously dense is considered dense tissue. So you really have to be familiar with your report and have a better understanding. So women with dense breast tissue should be having ultrasound imaging along with their mammography. So obesity, like I spoke to you a little bit earlier about the fact that women who are obese and have more body fat, their risk is higher, and it goes up pretty significantly for people who are especially morbidly obese. So things like breast cancer and endometrial cancer are actually obesity-driven cancers. It's especially important for us to be more lean once we hit menopause, because as I don't know the ages of everybody who's listening today, but any women who are postmenopausal like myself know that your weight does go up after menopause. So taking control of that and really adding exercise is important. Interestingly, if you have more fat around your abdomen, just like it increases your risk for certain other kinds of medical conditions, it also makes your risk higher for breast cancer as opposed to if you carry it in your lower body. So the recommendations actually is to have moderate exercise for 4 to 7 hours per week. That has actually been shown to lower your risk. For any people who have ever heard of the medication tamoxifen, they actually did do a study which did show that the exercise lowered patients' risk just as much as if they took tamoxifen, the medication that helps lower breast cancer risk. And again, healthier lifestyle is important. So diet does play a factor. They have shown that really the Mediterranean diet, which is lean proteins, and lots of fruits and vegetables, does actually help with your risk. We do have a dietitian that's associated with our high risk breast cancer program at Atlantic Health, which is actually free to patients who are enrolled in the program. So I'll talk a little bit about hormone replacement therapy. So back in 2002, there was a very large study that occurred that studied women who were taking hormone replacement therapy. And actually, the study was ended prior to completing because they did notice a significant increase in women developing breast cancer who were taking hormone replacement therapy. They did actually restudy it again in 2019, and they did receive similar results. The combination hormone replacement therapy, so that's estrogen and progesterone together, was found to actually increase patients' risks up to 75%, really in the first couple of years after starting it. And that's not plus 75%, that's 75% of your personal risk. So once you stop hormone replacement therapy, though, your risk does go back to average after a few years after stopping it. Some women can take estrogen alone. That's women who have actually had hysterectomies. So you cannot take estrogen by itself when you have an intact uterus, meaning if you haven't had your uterus removed, you're not a candidate to just take estrogen by itself. And if you are a candidate for that, you can take estrogen therapy alone, but it does increase your risk once you've been taking it for about 10 years. Now, there's all this talk out there now about bioidenticals. There are specialists. You can get hormone replacement therapy from providers online. But the risk is the same for these bioidenticals. It is still a hormone. So those hormones do carry the same exact risk for your hormone replacement as regular traditional hormone replacement therapy. Birth control pills, that's been studied. Millions and millions of women have been studied with birth control pills, and they only really see a risk when women are taking the birth control pill for more than 30 years. So vaginal estrogen is okay. So people who take Vagifem or anything for vaginal dryness or urinary incontinence, that's a localized treatment. So that's not really absorbed systemically. So having vaginal estrogen, is okay. I did include this little graph or chart down at the bottom here, and this is really a chart that's recommended that prescribers use when they're considering prescribing hormone replacement therapy for patients. So to the left, it talks about your risk category. So if you don't have like any of the risk factors that we talked about earlier, and you're at low risk, then it's really okay to take menopausal hormone replacement therapy. You still have a higher risk, but your risk is low to begin with. So we start to get to intermediate or high risk. It really should be used with caution or avoided altogether. So these words NCI or IBIS score are different scores that we use to calculate a patient's risk. So at Atlantic Health System, actually, if you have your mammogram through our system, you will fill out a tablet at the time of your mammography, and it will generate a risk score, and that'll be printed out at the bottom of your mammography report. If you're at elevated risk, you'll actually be called by a representative to talk about that and possibly make an appointment to participate in the high-risk breast cancer program. So if you're at high risk, having hormone replacement therapy is not something that would be recommended for you. So cigarette smoking is bad for you for a lot of reasons, but it definitely adds to your risk of breast cancer. It could be as much as 50%. It depends on what age you started smoking, how long you've been smoking for, and whether your family has had lung cancer previously from cigarette smoking. So there are continually studying secondhand smoke exposure, and they think that there's a possible risk, increased risk of breast cancer associated in postmenopausal women with secondhand smoke exposure. But those results are not quite out yet. Other important reasons not to cigarette smoke when we talk about breast cancer: if you're having surgery on your breasts, like a mastectomy, or even having some of your a lumpectomy, or you have to have surgery for cancer, or just prophylactic surgery, it's hard to heal. So it really limits your reconstruction options. So there are certain types of reconstruction if people have a mastectomy that we cannot perform on people who are smoking. It also increases your risk of blood clots. So women who are cigarette smoking, even if they have a low risk, should not take hormone replacement therapy because it puts you at high risk for stroke. So this is my least favorite slide because I do like a little wine. Alcohol does increase your risk of breast cancer when you consume large amounts. Now, I'm not talking about your vacation time where you may be drinking 24 hours a day. For your week of vacation, it's more consistent. So if you're having 4 to 7 drinks of alcohol per week, your personal risk does go up by about 10%. And again, it's personal risk. So if your risk was 10%, your risk would then be about 11%. But each additional consistent drink per week, your risk does go up by additional 10%. If you've had breast cancer before, even a lesser amount per week can increase your risk of breast cancer. Limiting alcohol is also helpful. So we're going to talk about another little funny here. I don't know if anybody's laughing. We're going to talk a little bit about imaging and early detection. So early detection means you want to catch breast cancer early. So again, 95% of breast cancers found on routine imaging are curable. Mammogram is the gold standard. So anybody at age 40 or older should be having a mammogram once a year. It is free. Federal law says that women at that age range get a mammogram for free, and you do not need a prescription for that study. When you call to make an appointment, especially even in Atlantic Health, you can say that you're self-referred. Some of the outside smaller centers don't like to do mammography without a prescription. And that's really because if you go self-referred, the results go to you. They don't go to any medical provider or anything like that. So you are left with those results. So they want to make sure that if there's a problem, that there is a medical provider that's available to handle those results. But the fact of the matter is that you don't need a prescription for it. So tell your friends, anybody 40 and over should be having your mammograms. And like we talked about before, if you have dense tissue, ultrasound imaging is also recommended. And doing self-breast exams, being aware of how your breasts look and feel is an important part. And a clinical breast exam just means that you see a healthcare provider. It's recommended once a year to have a breast exam by them. And that could be your primary care provider, a breast specialist if you're at elevated risk, or your gynecologist. So if you're at high risk, there are other things that we do to monitor you. So in addition to your monthly self-breast examination and that mammography and ultrasound, if you have dense tissue, you may be getting MRI imaging. And we like to spread this imaging out by 6 months. So if you had your mammogram and ultrasound, we do that once a year. And then 6 months later, we do MRI imaging. Not everybody gets an MRI. It really depends on the density of your tissue. If your tissue is like that glass of water, we wouldn't necessarily be ordering an MRI, but anybody who's at high risk is evaluated for that. Within Atlantic Health System, we actually have what's called an abbreviated MRI. So it's just as accurate as a traditional MRI, but you're only in the machine about 8 to 10 minutes instead of the traditional half hour. So it is a lot more comfortable. Again, same thing, having that yearly breast exam, except when you're at high risk, you should be seeing a breast specialist as well as your gynecologist. And that way you're getting some sort of breast exam about every 6 to 12 months. Depending on your family history or if you've had any abnormal biopsies or breast cancer previously, you may be getting some genetic testing. We talked about the dietitian previously. We also have access to the metabolic medicine department here as well. So if you've been obese your whole life, we do have the ability to refer you to the metabolic medicine department to evaluate you for possible other medical issues that may be causing you to be overweight. There are certain patients who are at elevated risk that are can be eligible for taking certain types of medications. And I alluded a little bit before to the tamoxifen. These currently are prescribed by a medical oncologist. And these medications can reduce your risk of breast cancer by about 50%. They are not without side effects, though. So there is some side effects like joint pain and hot flashes and things like that that are a little harder sometimes to tolerate. So we really reserve prescribing these things for women who have had abnormal biopsies or may have some genetic mutations that increase their risk of breast cancer pretty high. So somebody who has a BRCA mutation, for instance, certain types of BRCA mutations develop the traditional hormone positive cancers, but their risk for cancer is about 60 to 80%. So in that situation, some women who have not had prophylactic mastectomy may be a candidate to take some of this medication. Tamoxifen is taken if you're premenopausal. There's a very small 2% risk of developing an endometrial cancer when you take tamoxifen. And then there are other types of medications called aromatase inhibitors, but those can actually increase your risk of osteoporosis. So everything's kind of used in caution. So it's all about weighing the risks and benefits. I've mentioned mastectomy a few times. That really is a procedure that we do where we remove the breast tissue. And that's really reserved for people who are at really high risk. So patients who have BRCA mutations or patients who have other types of mutations that may put them at risk for breast cancer with a very significant family history. Sometimes women who have very frequent biopsies and very dense breast tissue, and it's just very hard for us to do imaging to potentially catch a breast cancer may be eligible. But it's not something that we jump to. It's a life-changing operation. So we don't jump to it I would say it's a very small portion of patients that actually are just at a high risk without genetic mutation that we offer having a mastectomy. Some people who have the BRCA mutation or other mutations that may put you at risk for ovarian cancer as well as breast. That fancy word salpingo-oophorectomy means that we take out your tubes and your ovaries. When we do that, that does also lower your risk as breast cancer as well, because you are getting rid of those hormones like the estrogen and the progesterone that are really driven from those ovaries. And slide is not advancing. Just want to make sure. I don't see that the slides are moving. There we go. Okay, so anyway, this is my contact information. This is the main phone number at my Morristown office. I am also in practice at the Rockaway office. When we first started the program in January of 2019, it was at Chilton and Morristown. So now I started with one patient back then, and I have about 3,000 just myself now. And so we've progressed quite nicely. We're now located in multiple locations. So there's locations at Newton area, Hackettstown area, Morristown area, Chilton area, Bridgewater, Overlook, and of course, Morristown. So if you believe that you're at elevated risk, feel free to contact us. There's the phone number there, as well as online. You can find the phone number. I think there's also a QR code that's available. There's a phone number to schedule a mammogram. And if there's anybody out there that is cigarette smoking, we do have a pretty active and successful smoking cessation program here at Atlantic Health System. So again, there's that. 95% of breast cancers found on routine imaging are curable. So please get your mammogram.
In the chat, you'll see a link to our survey for today's webinar. So we kindly ask that you take a few minutes after the webinar to complete the program survey. It's in the chat, but it'll also pop up when we close the meeting. A special thank you to Lynn. Thank you for dedicating your time and your expertise. If folks have additional questions or comments, you can also send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. That concludes our webinar for this afternoon. Thank you, Lynn.
Welcome.
Thanks, everyone.